I'd now like to ask Kasia and Jeanette if you could make yourself available for the moderated question and answer session. I'd encourage people, if you have questions, that you place them in the Q&A section on the webinar. And as I think I said at the outset, if there are particularly questions that you would like, that you see up there, but perhaps you haven't put yourself, that you would like to have answered, then please vote for those as well. It's a way of helping us to understand what are the sort of the main priorities in terms of questions and how we proceed in terms of prioritizing them. So there are a few questions there just at the moment. I will perhaps get underway with one that's directed to you first, Jeanette. There's a question here that says, you described Lenny as experiencing collapses in the waiting room prior to appointments. Does this mean that she would lose consciousness?
Yeah, so typical presentation is, as I describe, that she will clutch her throat, she will perhaps yell out, she will become very stiff, lose consciousness, and then her body will shake, or all of her muscles will shake. Gradually her muscle tone will become softer and she will come back to consciousness, and it'll take a little moment before she's right back in the room. So yes, and then I would work with her after this has happened, still bring her into the room, and we'd do some mostly body focused attempts to just increase that regulation and practice some of those things to decrease, just reinforce that decreased arousal.
Great, thank you. There's a question here, perhaps I could direct towards you, Kasia. It's asking, is dissociation a functional seizure?
So I don't know if you remember that slide where I showed all the names, and I think one of the names is dissociative seizures, and the current adult task force for the International League Against Epilepsy, their preferred name is functional dissociative seizures, because what we're talking about is a change in brain state. And of course, that's exactly what dissociation is. So you have this sort of continuum of different presentations. And it'll vary between patients really. But some of my patients will have, you know, multiple different ways of presenting, like collapse might be one, they might have shaking, but then they might go into sort of dissociative episodes as well. So, you know, if you think about it as dysregulation in neural networks, change of brain state, it sort of simplifies thinking about it in the context of a very high arousal. Yeah.
Okay, thank you. There's a question. There's a couple of questions here about the appropriateness or the evidence for treatment of functional seizures with the help of EMDR. Are you able, perhaps both of you, perhaps to you first, Kasia, is there any evidence that EMDR may be used to treat functional seizures? And then maybe you might want to comment on that too, Jeanette.
I don't know if Jeanette knows, but I don't know of any studies specifically looking at EMDR. But clearly, if, for example, you know, some of my patients, you know, that they say a trauma memory will trigger the functional seizure. So clearly, if you process the trauma and you don't have some of the trigger coming up all the time, it's obviously going to help your functional seizure. So, I mean, Jeanette, do you want to comment?
Yes, I do. I think in my, I'm trained in EMDR, and one of the contraindications is dissociation, because the client needs to be able to focus all the time. They need to be in the presence of their memory, and they need to be able to focus on the actual action that they're asked to watch with their eyes, or, you know, through tapping or some other form of bilateral brain stimulation to try and get all of the brain working at once. And if they dissociate, then they're not doing that. So that's a difficulty. So that's an assessment prior to doing EMDR. I have heard anecdotally, but I haven't read the evidence, that there's some ideas that you can do something a lot briefer to cope with people who do dissociate, but I'm not familiar with that. I cannot comment on that specifically, but I've seen it referenced just recently.
I think there's you know, some of the people who use tapping don't actually focus on the memory. So I think my view is that trauma processing interventions which you don't need to focus on the memory as much are much easier than ones that you need to focus on the memory, because sometimes you just can't actually get through the process. And I think the one you might be referring to is something developed in the US, which I haven't seen done either, but it's called ART.
ART, yes.
Yeah. And I'm particularly interested in it exactly because of that, because you don't actually have to focus on the memory at all. And I think for this patient group, it would allow you to sort of get around the trigger and still be able to process the trauma. Yeah, and it's I can't remember what it'll come to me what ART stands for. Yeah.
ART, yeah. Maybe we'll keep on with that. We'll get a couple of questions further.
Accelerated resolution therapy. There you go.
All right, thank you. Okay, we have another question actually about trauma processing work. So I think this is a question for you both, and I'll direct it first to you, Kasia. How would you approach trauma processing work to avoid bringing on a functional seizure, particularly if a client is insistent on detailed disclosure?
Well, I mean, I think you have to do all the, I mean, the reason I presented the material the way I did is I just presented the bit about managing the functional seizures, and I would not be doing trauma work if a patient had no capacity to manage her or his functional seizures. I mean, you're looking at safety. And I mean, you know, it seems very simple, the 5-step plan, but actually working through any of those steps can take weeks to months. And I think that was beautifully shown by Jeanette, where the holding in the therapeutic session allowed, allowed the woman to manage, but she hadn't generalized that in any way, like in her, home setting. She hadn't been able to increase her self-efficacy and like doing that by herself. And so I think, safety is very important. So I think you have to be able to use, you need to be able to manage your seizures to be able to do some of the trauma processing, because it's going to stir everything up. And so you don't want to be starting at zero. And I think you have to negotiate what's appropriate. So I certainly would not be, going into full disclosure, everything in great detail, because I think that re-traumatizes people. And I would be, thinking of doing things in ways that require the least direct sort of exposure of memories, which is again why I'm so interested with some of these newer processing, because it's also the safety of the practitioner. That's the other thing. I mean, practitioners don't have to be needlessly traumatized either. So there's two people being re-traumatized here.
Thank you. Jeanette, do you want to have a comment?
Yeah, I just have something I'd like to add, is that in the case of my client, I think the client is re-experiencing this all the time anyway, whether she vocalizes it or whether she's living it just by sitting in the session or whatever's going on with her. It's not that I'm stopping her from re-experiencing it by some work on that area, but that's not what my focus was. My focus was very much safety, so I very much agree with what Kasia said, that it's about managing the situation, it's about building the skill base, but it's impossible to not deal with those things, because those things are part of the process. So that's why I've emphasised my intervention as a holistic way, that it wasn't clearly a step by step by step. It's a back and forth, and it's a management, and then more management, and then more management, and gradually I've given a summary story, but this has all been bits and pieces over a 2-year period.
Yes, I noticed from your slide it's over 2 years and something like 80 sessions. I think
Yeah.
Can I just build on what Jeanette said, because I think that's a really important point. So I think, you know, like with kids, you can get very simple presentations where you can actually, where the sort of stressor is fairly, you know, minimal, it's academic stress, or, you know, there's been some mild bullying at school or something, and you can actually treat that presentation very quickly. So there isn't a lot of other bits to do. There might be some, you know, you have to do a school intervention, you might have to do a sort of specific learning plan, but there isn't a lot of other things you can do. So you can actually sort of, you know, if you get a good history, you have a good engagement with the child and family, you can actually treat that pretty quickly. But the more layers you add, and the more trauma there is, then the more complicated that process becomes. And you can't do a simple intervention. It's this, you know, going backwards and forwards, because you get stuck and then you have to treat another layer, then you have to go back. And I think that's really important to conceptualize, because it's the range of, you know, the context, like the context of the story that functional seizures present in, it varies very, very broadly. And at one end is very quick, and the other end, it's years of therapy with, you know, without necessarily full resolution. Whereas at the other end, you're wanting full resolution very quickly. So I think that point Jeanette made is just very, very important.
Mm-hmm. Okay. A question here about, perhaps I'll direct this one to you, Kasia. How do you work with children who are experiencing functional seizures but are pre-verbal?
Well, so the interesting thing is that you don't see many functional seizures in pre-verbal children. So I think in children, I think the mean age of presentation is about 12 to 14. I think the youngest, there are reports of very young children, like 3 years of age, but it's very rare. And you'd still be looking at settling the stress system. So you would have to work through, you know, parents, through play, through, I mean, you're still doing the same things, except you would have to scaffold the child much more. And that's the same with intellectually impaired children. The amount of scaffolding you have to put around them from, you know, parents, family, is much more, because they can't always do it by themselves, or they need to be prompted to do things, you know, and they need a lot more scaffolding to engage in what they need to engage in to calm themselves.
Yeah, and I suppose even at 3 years old, they probably wouldn't be entirely pre-verbal, you know, but yeah, okay. Thank you. This is, I think, a sort of a further question going back to what we talked about, the trauma processing work. That, you know, the question is, isn't the client in those circumstances re-experiencing or reliving their traumatic experiences during the dissociative episodes? I think, yeah, I mean, this is where, I suppose, referring Jeanette to your client who was having, you know, multiple functional seizures per day. And yeah, I think that point you made, that re-experiencing or reliving is going on in any event in those situations. Yeah. Okay. I've got a question here about.
Sorry, can I make a point around that? Just that, you know, in children, the number of children who've had maltreatment of some sort probably goes up to about 20, maybe maximally 30%. In adults, it's higher, but there's a lot of individuals with functional seizures who do not have trauma.
Right.
So you can't make, you really need to do your biopsychosocial holistic assessment, because you can't have the same formulation for everybody, because everybody's different, and you actually have to do it very carefully for that individual. So you're not assuming something that's not true for that person.
Yeah, that's a very good point. Thank you. Another question about capacity to see neurologists, and it's been, so is the process of seeing a neurologist a difficult one for clients from refugee backgrounds? You know, around EEGs in rural and regional areas, there's issues around access and cost. So wondering how this can work when significant numbers of a population may be experiencing functional seizures, as per what I think you referred to, Jeanette, in the statistics for the client group that you're working with. So any observations on that?
Oh gosh, I could talk quite a lot on the problems of rural and regional access to health services, totally confounded by COVID as well, because it meant that in our rural area, where people might have gone to one of the capital cities for their specialist appointment, during COVID they couldn't travel. So that meant that the one regional person with a private practice was so overloaded that the waiting list was impossible. So yes, there's a lot of problems around that area. So I've only touched on one aspect. We probably haven't answered the full question.
No, that's helpful. Thank you. Yeah, I'm not sure if you have any observations on that too, Kasia.
I think, yeah, no, I think it's very tricky. I think also neurologists, you know, haven't been good at doing this type of work and being upfront about it, because, and there's a lot of work in the field at the moment in terms of, you know, giving a clear positive diagnosis very quickly, which they actually can do with an EEG. And the neurologists are fantastic from video material and an EEG in being able to make a positive diagnosis. So you don't need the top-notch, you know, like the top-notch investigations for most people. In actual fact, you can make a pretty good diagnosis with some video material and a normal EEG, which is actually quite available everywhere. So there's a lot of work being done in trying to get these processes to be smoother, because they shouldn't be so hard. It's not, this is not difficult medicine.
Okay, thank you. I think, look, we're coming to conclusion, I think. I'm just looking through to identify if there are any other questions that people may have identified. Yeah, we have one question that's been placed actually in the chat. So just to thank Lenny for allowing the story to be shared. This person's curious about differentiating FND symptoms and trauma symptoms, such as hyperarousal, flashbacks, and dissociation. How do you consider diagnostically, and how does this impact the treatment approach? Maybe Kasia, do you want us to? Yeah,
so FND symptoms are pretty straightforward, except for functional seizures. So other FND symptoms like paralysis or motor loss or loss of sensation, they're all very straightforwardly diagnosed using a neurological examination with positive rule-in signs. So that bit's easy, and you just need a good neurologist who's comfortable saying, actually, this is FND. That's the problem. With functional seizures, it's a bit more tricky, because you do have this multiple broad way in which functional seizures can, you know, can show themselves, which includes like dissociative states. And so I think you're starting to get overlaps of different constructs there with functional seizures, where one person will call it this and another person will call it that. And that's why I put all those names up, because I wanted to sort of tap into, you know, some of the overlap in presentations. Yeah.
Okay.
Yeah. Can I make a comment on that too?
Oh, yeah, please
From
go ahead.
the perspective of a counsellor making interventions, the interventions around managing physical body arousal are the same kinds of interventions for decreasing arousal that might lead to functional seizure, or decreasing arousal that might be associated with flashbacks or associated with intrusive memories or hypervigilance or all of those kinds of things, from that very practical learning some skill set and teaching some skill set and practicing perspective. And I think similarly for some of the ones that are a bit more psychological, that might be to do with like some of the visualizations that I discussed that were helpful for Lenny, where she would think about a flower and use her senses in her visualizing, or think about her children and use her senses thinking of their, you know, happy voices and their smiling faces and the texture of their hair and all of those kinds of things. So I think there's something similar there in the types of interventions that might be helpful to decrease arousal.
Mm-hmm.
I think Jeanette's point is vital, because I think when and that's why I showed some of that neurobiology, because because if you get that, you can understand that you're actually trying to calm the body and brain. And whether, you know, as Jeanette said, whether it's PTSD that your symptoms are presenting at, dissociative episodes, flashbacks, whether it's functional seizures or some other FND symptom, you actually need to calm the body and brain, and actually good therapists already have those skills. So the message is that actually most good therapists have the skills they need. They just need to sort of think about functional seizures a little bit differently and put them into part of what, you know, their scope of practice, because they actually have the skills to treat them. They don't have the skills to diagnose them, but they have the skills to treat them. Yeah.
Mm-hmm. Thank you. Perhaps one final question, because we're coming to a close in terms of our time together. This question is, how is the brain change that you spoke about as the root of FND related to a dorsal vagal collapse? Are they similar? Does this mean a relational component of establishing safety is helpful? Do you want to take that one on, perhaps, Kasia, to begin with?
I can take that on. So you're talking about, you know, polyvagal theory, which specifically talks about the autonomic nervous system, and the autonomic nervous system is one of the bits of the stress systems in the brain and body that's activated. And certainly, you know, it's part of the picture, but it's not the only bit of the picture. So I think if you're thinking of it on a systems level, it's certainly part of the picture. And the with functional seizures that present as collapse, they usually don't actually have the activation of the parasympathetic that Paul just talks about. They don't have decreased heart rate. They don't, you know, become cold. So actually, that mechanism isn't the mechanism that is driving functional seizures. However, the activation bit with the sympathetic system and the decrease of the restorative vagus, like the good vagus that you want to calm yourself, is affected. So these systems are interconnected, and certainly the autonomic nervous system is one of the systems that is going to be overactivated in you know, this group of patients.
Okay.
Could I just ask a question of Kasia? Lenny alternately or describes that she either feels very cold hands and slowed down, or she feels very activated as things that might happen prior to a functional seizure. I'm curious about that. Would you have a comment about that?
So I think what I would think is happening, you also said she clutches her throat.
Mm.
So you know, I'm hypothesizing, but my sense is that she's probably starting to hyperventilate is one of the things that happens, which then feels like she can't breathe. She's also having activation of the autonomic nervous system, which initially makes you feel hot. But if you reach a ceiling with the sympathetic system, like hitting a ceiling, you might then activate the parasympathetic, the defensive parasympathetic, in which case she may then get a drop of heart rate, feeling slow. So it's sounding to me like she's activating at different levels of that system and activating different bits in different presentations. Does that make sense? But it'd be very nice to have a little monitor and see whether you could track it. But that's what it sounds like. Yeah.
Thank you very much, Kasia.
Yeah. Look, we have one final question, which I'll send your way, Jeanette. As therapy progressed, have you noticed that the episodes, the functional seizure episodes during sessions got shorter in terms of their time, or did they remain at the same sort of duration?
Oh, that's a very interesting question. And I would say that sometimes now I'm seeing some shorter collapses, but I'm actually seeing less collapses. So I've got less to judge from. And sometimes I'm seeing collapses that don't go to complete unconsciousness. So the range that I'm seeing has changed. It's really hard for me to judge. I think when I first started seeing them, my sense of time was distorted and they seemed much longer. So perhaps I have become more familiar with the presentation. I haven't timed them, is what I'm saying, and that I couldn't definitively say they've become shorter in a way that's completely obvious, but I think they have shifted and changed.
Mm-hmm. Great, thank you. All right, look, I'd like to take this opportunity to thank you both. Thank you to you, Kasia, for a really illuminating presentation, and thank you as well, Jeanette, for what was a terrific presentation of your work with your client, and really very interesting approach you've taken in working with what is clearly a really quite a challenging situation for the client. So thank you to you both. It's really been really very helpful, and we've had some really positive comments in the chat tonight from a whole range of people who've been on the line. We've had more than 80 participants with us tonight. So thank you both. We appreciate you both taking the time to be with us this evening.